I'll begin to introduce our speakers today. First is Katie Rogers. She is the Chief Nursing Officer for the Norton Medical Group and Norton Cancer Institute. She's a thoracic surgery nurse practitioner, and for more than 20 years, she's taken care of patients with lung cancer. She has a passion for prevention, early detection, and surgical and medical management of lung cancer, and she has no relevant relationships to disclose. And next, I'll introduce Dr. Adam Lai. Dr. Lai attended medical school at the University of Kentucky, where he also completed his residency and fellowship. Prior to joining Norton Healthcare, Dr. Lai was the medical director of oncology in Elizabethtown, Kentucky, where he built and established a robust practice in that area. After admiring Norton's market presence and comprehensive oncology program for 5 years, Dr. Lai decided to join Norton formally in July of 2018. He now practices at NCI Brownsboro, practicing general oncology and hematology while focusing on the newly established multidisciplinary thoracic program. Dr. Lai has the following relevant relationships to disclose: with Bristol Myers Squibb as a speaker and consultant, and Merck as a speaker, and all financial relationships have been successfully mitigated. And so now I will turn the program over to our speakers today. Thank you all for joining us.
Hey, thank you, McKenna.
Hi.
As stated, I do have a passion for patients. I'm Katie. I do have a passion for patients that are diagnosed with lung cancer, and more importantly, around lung cancer death prevention. In my practice, it was heart-wrenching to take care of patients that were diagnosed with advanced stage cancers, knowing that we had a way that we could screen them that really could help prevent their death if we were able to detect their cancer earlier in their disease. Today, Dr. Lai is going to present specific details around lung cancer diagnosis, management, and prevention. Specifically, I wanted to start this conversation off with some thought-provoking comments. This information may not be new to you, but it is important to take pause and recognize how we as clinicians can better care for our community, the communities with where we have our practices. First off, where you live does affect your health outcomes. For example, from Cherokee Triangle to the Russell neighborhood, which is only about 4.6 miles apart in distance, the life expectancy difference is 8 years. As a leading healthcare provider in this community and as clinicians, it is our responsibility to address this disparity. Specific to lung cancer, we know that in the Russell neighborhood, the incidence of death from lung cancer is higher. This also correlates with a decrease in screening rates in that area. So out of the gate, there's already an opportunity where we can step in and do our part in knowing that information and be more acutely aware of how we can impact and ensure that we're doing screenings. This is just one example of a focus area that we as clinicians need to really step in and acknowledge and change our practice and expand our practice. So that I just wanted to introduce that and kind of level set where we were heading with this. And I'm going to hand it over to Dr. Lai, where he is going to give us an expert information around pursuing health equity in lung cancer care. Thanks, Dr. Lai.
Mm-hmm. So I'm Adam Lai. Is it switching over?
You're on. It's
okay,
all you.
Great. All right. So my name's Adam Lai. I'm medical oncologist here at Norton Brownsboro. I've been at Norton for about 4 years. So in my practice, I see primarily lung cancer, see other kind of cancers too, but really focus on lung cancer. And one of my passions really is just trying to help Kentucky with our problem. I mean, we have a massive lung cancer problem, as I'm going to show you. And, you know, we're the worst state for lung cancer. We're the biggest city in that state. And I think we're the premier healthcare system in that city. So really, this is what we should be focusing on. And I'm hoping that the data I provide today will maybe empower some people and energize some people to help us in that fight. So again, we're going to be talking about lung cancer disparities in greater Louisville. The objectives of this talk, we're going to look at inequities in the screening and treatment of lung cancer. We'll look at some possible root causes and try to define those. And then we'll discuss the need to change to improve lung cancer health equity in our community. So really, when I set out to make this talk, I was trying to think of the best way to do this So I split it up into 3 parts. So part 1, we're going to discuss the severity of lung cancer in Kentucky and the US. Then we'll switch to part 2, the treatment advances in lung cancer. And I hope to awe you and inspire you that we've come a long way in our understanding of lung cancer and the outcomes that we can provide patients for lung cancer. And then part 3, we'll discuss some of the disparities in lung cancer care and some opportunities there to improve our care. So part 1, again, we're going to outline the severity of lung cancer in Kentucky and the US. So when we look at US death rates by age, if you're over the age of 65, heart disease is the biggest killer, but cancer is really not far behind. And then if you look at less than 65, actually cancer is the biggest cause of death. So lung cancer, whether you're young or old, either one, it's either the number 1 or number 2 killer. So when you look at the scope of this problem in the US, you look at the new cancer cases. So lung cancer cases, number 3, as far as the volume, so about 235,000 or so. But then when you look at the deaths, it's by far the biggest cancer killer. So if we look at that another way, I think this is easier to visualize that. So here are your lung cancer deaths here on the left, and you can see that it really is almost as large as the next 3 cancers combined. So lung cancer is by far the biggest cancer killer. So switching to new cancers nationally, Kentucky data, unfortunately, Kentucky is the number 1 state in the country for lung cancer, or excuse me, for cancer rate, and it's really not even close. You can see Louisiana and Arkansas are a distant 2nd and 3rd. So again, not something we want to be ranked highly in. When you look at cancer incidence in Kentucky, so here again is lung cancer incidence on the left. When you look at how much worse our lung cancer is than some of our other cancers in the state, you can see that lung cancer far and away, for many reasons, we have the worst incidence compared to other cancers, and that's above the national average. When you look at mortality, of course, lung cancer is number 1, but this is really striking. When you look at the percent difference, so we're 55% higher than the US average, but you look at the next, I guess, worst cancer in our state, and it's not even close. I mean, lung cancer is just such a killer for our Kentuckians that it's a major problem. So when you look at new lung cancer cases by state, again, here we rank 51st among all states, and DC, we're in the bottom tier there. A bit of good news, over the last 5 years, the rate of new cases has improved by 11%. You can see where we are compared to the national average. We are not doing well. So this is really the crux of the problem and how we can help people with survival. So when you look at the stage of diagnosis, so here, this green area, this is your advanced cancers, okay? So about 46% we're catching at stage 4. And so that's when they're diagnosed. Now, if you look at that compared to the survival, I mean, obviously, the earlier you catch the cancer, the better our patients do. So if we could somehow shift these cancers that we're finding late and find them earlier, we would really make a marked improvement in our ability to help patients and help patients survive this disease. So as it stands, we're 45th among the 49 states that have data on this in catching cancer at an early stage. However, this has improved in Kentucky by 45%, and I'll show you why that is here in a few slides. Smoking, of course, is a major risk for lung cancer. Depending on the data you look at, we're always in the top 3. Oftentimes we're number 1 or number 2. Here we're ranked 49th out of 50. West Virginia is barely worse than us, but we have about a quarter of Kentuckians that continue to smoke, and that's significantly higher than the national rate of 15%. I put this on here. This is a talk, of course, about lung cancer, but there are many other cancers that are smoking related. And so when you're talking to patients about smoking cessation, it's not just lung cancer that they would benefit from quitting smoking. It's quite a few others. Now, switching to a more local level, if you look at the Jefferson County population, almost half of the Black population lives in Jefferson County, 46.5%. So we take care of the majority of, as far as the county goes, of the Black population right here in Jefferson County. If you look at cancer death rates, so if you practice in one of these areas, this is your problem. This is our problem. We need to work on this together. These are the zip codes where we have a problem with lung cancer mortality rates, and we need to do better. So, this just really drives that home. Here is Norton's unique lung cancer patients. Again, you can see the same area. It almost overlaps with that last slide. But if you're in any of these zip codes, this is our problem. This is where these patients are being identified and where we need to provide better care for them. So part 2, we're going to shift gears now and look at treatment advancements in lung cancer. So one of the things I want people to take home is that lung cancer is not the same disease as far as our understanding of it or how it's treated or the outcomes that it was, 20 or 30 years ago. We really don't give chemotherapy alone anymore. I haven't done that in probably, 8 years, maybe longer than that. We now have targeted treatments, which oftentimes are pill treatments if we can identify molecular targets. Those patients on pill treatment, they do better than if they would get chemotherapy, and they have less side effects, and oftentimes significantly less side effects. So that's a win-win for them. Some patients are able to use immunotherapy alone, which is harnessing our own, natural cancer killers, the T cells. So this cartoon I have in the top right corner is of an activated T cell that's attacking a cancer cell or a tumor there. And so we're now able to harness the power of our own cancer killers to go after these lung cancers. And again, that's with much less toxicity than our patients would have seen with chemotherapy alone 20 or 30 years ago. For most of my patients, they're able to get immunotherapy and chemotherapy together up front right away. So that is really making a difference, as I'm going to show you in a minute. If patients are found to have very early stage lung cancer, then surgical resection still remains the gold standard for curative surgery. And then if they're not a surgical candidate or they refuse surgery, stereotactic or pinpoint radiation is also a newer option for curative local control. And we often offer that to our patients as well. So this is a slide that I added for this talk. So this is just looking at some of the immunotherapy trials over the last decade, really. And so if you look at for each trial, if you look at the top row compared to the bottom row, anything you see here is improvement, okay, over chemotherapy backbone. So you can see that in almost every trial we've had significant improvements in treating lung cancer compared to chemotherapy alone. The toxicities are over here on the right. Most of the time, immunotherapy has less toxicity than chemotherapy. If you add immunotherapy to chemotherapy, you really get very little, in my opinion, significant added toxicity, and most patients tolerate this very well. So again, I want to drive home that this is no longer the same disease or treatment that you're probably familiar with. It's a very complex disease to treat, and it's getting more and more complex every month that goes by as we're getting more drugs and more targets and more mutations to test for. A lot has changed from the decades of the 1990s and 2000s. So if you had, parents, brothers, sisters, neighbors, friends that were treated, 20 or 30 years ago, their experience is going to be totally different than a patient today. So I have some patient examples. I've really pared this down. The talk I did earlier, I probably had 12 or 15 of these. But all of these are real patients. These are my patients. They're all still alive today, and they all had or have stage 4 or stage 3 disease. So my first patient is BH. She's a 36-year-old female non-smoker. She actually presented with a stroke and had stage 4 disease involving the bone as well. She required 4 biopsies. So they initially did an FNA of her lung. That didn't show any molecular target. I had a bone biopsy done. I still didn't get a molecular target. I did a liquid biopsy, which is a blood draw where we can collect circulating tumor DNA to look for molecular targets. There was none there. So still not believing it, I did a core needle biopsy, and that identified a RET exon 12 mutation. So she is on a pill treatment, which is a targeted treatment. And you can see the improvement in her CT imaging here in less than 3 months on targeted treatment. She went from a rapidly advancing cancer to basically back to her baseline in about a month. It was pretty remarkable. So here's another patient. She's a 63-year-old female non-smoker, a medical professional. She had stage 4 disease at presentation, presented with stage 4 adeno of the lung, had a malignant pleural effusion and pleural involvement, no target mutations, but did have a PD-L1 level of 60%, which is the target that we use for immunotherapy. This is about 1 year between her scans, and you can see a significant improvement. I think she just had her 2nd or 3rd grandbaby and is doing really, really well. Here's another patient, KP, 70-year-old female smoker with squamous cell lung cancer. She presented with 3 brain metastases, which were treated with stereotactic radiation. She had a PD-L1 level of 0%, stage 4. She got carboplatin, paclitaxel, and pembrolizumab together, and you can see about 4 months between these scans. She's still doing very well and has received quite a few treatments to this point. There's another patient, 62-year-old smoker, very large tumor at presentation. Adenocarcinoma, PD-L1 was 20%, stage 4, got combined chemoimmunotherapy, and you can see about 3 months or so between these scans. Still doing very well. This one I put in just as a reminder that when we do screening or we do imaging, it may look like lung cancer, but not everything is lung cancer. So this is a 54-year-old non-smoker. He presented with wheezing, and this biopsy actually showed melanoma. His PD-L1 was 60%. He had stage 4 disease. He received doublet immunotherapy, and you can see these are about 3 months between each scan. He's still doing very well. He's an engineer, flies a plane for fun, and is still doing everything he wants to do. So that's some good news of mine. Here's some more good news of the country. So when we look at recent trends and deaths, you can see the improvement we've made. So here for males, you can see our annual percent change of about 5.4% improvement. And this is from 2015 to 19, and almost the same thing in females. So we've really made a significant improvement in our treatment of lung cancer. So 5-year survival for lung cancer. Our 5-year survival is now, I would say, probably 25% or higher. That, you know, this data is a little bit older, but we're really doing much better. I'd say 20, 30 years ago, 5-year survival was probably about 3 to 5%. So you can see the significant improvement that we've made in lung cancer treatment. So again, this is no longer the same cancer that it was 20 or 30 years ago. So when we're trying to diagnose cancers early, this is a huge tool that we need to all be using. So lung cancer screening is here, and we need to all be doing it. So this was the initial paper published in 2011. 54,000 patients enrolled, so a huge trial. You can see the dates that they were enrolled. Very important on the initial trial, they had to have 3 things to be a candidate: age 55 to 74. They had to have a 30-pack year smoking history. So for instance, 1 pack per day for 30 years would be 30 pack years, 2 packs per day for 15 years would be 30 years, et cetera. And then if they had quit smoking, they were still eligible if they were within that 15-year quit date. So what is lung cancer screening? It's a low dose non-contrast CT scan. The radiologists tell me it takes about 10 or 20 seconds. The whole appointment should be completed in under 30 minutes. Again, you do this once a year. There's no IV, so there's no pain. And then the read is read formally by a radiologist. And if there's any concern or a major concern, the patient is referred to a team like mine, and we review the scans and come up with a plan on what to do next. So what did this trial show? It reduced lung cancer mortality by 20% and all-cause mortality by 6.7%. Pertinent to this talk, 90% of the trial participants were white and had higher socioeconomic status than the general population, so they had more access to care. They had more tools in their toolbox, so to speak. So this trial led to a 2013 USPSTF recommendation to include lung cancer screening, just like we do for mammogram, colonoscopy, et cetera. So there are a few other caveats I want to point out. It does decrease substantially the risk of dying from lung cancer for your patients that are enrolled in lung cancer screening. Of course, we can't guarantee that we're going to detect all lung cancers, and we can't guarantee that those are going to be caught early. If patients do need a procedure like a biopsy, fewer than 1 in 1,000 patients will experience a major complication if they have a false positive. So anyway, there is a risk, I guess, to this procedure, but it's very low. I think the reward far outweighs the risk. We still need to encourage smoking cessation. So, you know, I've had patients that I think feel like they don't need to quit smoking because I'm going to be checking them. No, that's not true. They still need to quit smoking. And then chest x-rays really should no longer be used. That we should not be using chest x-rays to screen for lung cancer. So part 3, now we're going to switch to discuss disparities in lung cancer care and also what we can do about it. So when we think about Black smokers and socioeconomically disadvantaged folks, they have a greater frequency of early onset non-small cell lung cancer. So they're getting lung cancer at a younger age. They also have shorter smoking history, so they smoke less cigarettes than white smokers. So that pack year history is lower for them. And then they also have longer time since quitting. So, you know, that 15 years may be a problem. They have fewer quit attempts at smoking than those with more resources. And they're unfortunately more likely to be diagnosed at advanced stage. So, and because of that, they're less likely to receive surgery. So not only are they getting lung cancer at earlier age, but their cancers are more advanced when they're getting diagnosed, which is unfortunate. So Black smokers and socioeconomically disadvantaged individuals, they have a higher incidence of non-small cell lung cancer, higher mortality from non-small cell lung cancer, lower rates of treatment, and a greater chance of being diagnosed at advanced stage. So were Black smokers and other minorities vastly underrepresented in that trial I just showed from the New England Journal? The answer is yes. So how did we rectify that? Well, there was a 2021 update, so about a year ago, and we now have 3 new criteria. So if you remember, our previous age was 55 to 74. We've shifted that down and up a little bit. So now they can begin lung cancer screening at 50, go all the way to 80. The pack year smoking history has decreased from 30 pack years to 20 pack years. So hopefully we catch more that way. And then the 15 years quit range, that didn't change. But with that expansion, we increased eligible patients from 8 million to 14.5 million US adults. And really in this population that we're talking about today, we increased that population about 100% or so in the non-Hispanic Black population. So I think it's important to point out that this improved eligibility so we can capture more patients, but that hasn't necessarily changed any of the barriers or access to care that still remain. So here's what the USPSTF summary looks like on their website. So again, 50 to 80, 20 pack year smoking history. They're a current smoker or they quit within the past 15 years. So that is the current recommendation. So historically, there's unfortunately been low rates of participation thus far in lung cancer screening. Nationally, depending on the data you look at, 5 to 16% of eligible patients are enrolled, still quite low. Black Kentuckians, only about 8%, so still very low. Kentucky, actually, including Norton, is in comparison doing quite well compared to the national average. We're above this, one of the things we're above average in. I still think we're way too low. I mean, less than 1 in 5 eligible patients getting screened is too low, but we have a head start on everybody else, and we need to keep that up. But Black Kentuckians are not up to where we need to be, and we need to improve that. So why is that? Well, could be low referral rates from uninformed providers that aren't aware of the guidelines. There may be some uncertainty regarding the benefits of lung cancer screening. So why should I do this? How is it going to help me? There may be lacking or low support or less support and follow-up care for these individuals. Some studies show that there's lower adherence to follow-up. And then I feel that each step from their eligibility to follow-up represents an opportunity for us. And then finally, which I'll touch on here again, there are always financial concerns. So one study, just to highlight some of the barriers here, one study showed that 80% of eligible smoker had never even heard of lung cancer screening, and a significant proportion of smokers expressed shame and stigma as being important barriers to screening. So, they were embarrassed that they smoked, and they knew they shouldn't smoke. And so they didn't seek out the appropriate medical care. And these findings are likely to be amplified in marginalized communities as well. This study also found that patients' willingness or eagerness to be screened was increased after they were educated on lung cancer screening and what it was and how it would benefit them. So Black individuals have a significantly greater reduction in lung cancer specific and all-cause mortality after screening with low-dose CT. That's how we do lung cancer screening. So these individuals are really benefiting from lung cancer screening. In fact, they may be the population that benefits the most. So it's essential that with our high-risk Black patients in particular, that we give them this life-saving examination. So looking at Norton's lung cancer screening program, if you look at 2018 up to 2021, these are the total lung cancer screens we've done, 3,435 in 2018, increased up to 6,425 in 2021. We've done almost, I'm sure it's now over 22,000 lung cancer screens since the inception of our program. Our nurse navigators and staff are Following over 9,000 patients, we found 406 lung cancers since we've started this program. However, we got a lot of improvement. We have, at least 14,000 patients that are eligible that have never had a lung cancer screen. So when we look at this drilled down a little bit more, you can see from 2015 to 2021, the growth of the program, 107 patients up to 6,425. I'd like to draw attention to stage at diagnosis. A successful lung cancer screening program, really, we should be identifying these cancers at earlier stage where we can offer better chance of cure and better outcomes. And that's exactly what we're doing. So we're finding a lot of stage 1, stage 2, we still find some stage 4s, that's going to happen, but primarily we're seeing very early stage, which is exactly what we want to do. These are lung cancers that are curable and patients should do very well. So now talking specifically about barriers. So this was the community health needs assessment that Norton did. This is internal data here. So when we talk about patients and providers in our own system, here's why they don't seek healthcare. Okay, so 23% put it off because they can't afford it. Anything that's related to money, I put in green, so you can see how often that gets mentioned. 18% had problems with access to care. 17% had difficulty in finding a provider. And that also included things like just being able to take off time at work or getting transported to the facility. And again, financial barriers. 34% had economic issues, again, affordability, insurance problems, financial concerns. In fact, 7 of the 10 top 10 barriers were financial concerns. So 70% of the top 10 were money related. 23% have sometimes or often put off health care because they couldn't afford it. 75% had issues with healthcare literacy and navigation. It is confusing, and we're here to help with that. A lot of the people that were surveyed discussed ways to strengthen partnerships with the health system, schools, churches, other community programs. This is a kind of newly identified barrier. Nearly half identified trust in the healthcare system as a barrier. And 31% stated that being able to trust a provider was the most important aspect of choosing a doctor or provider. So more potential barriers are what we need to do. We need to increase access to doctors and specialists. We need to bring cancer screening to the local community. We need to reduce physical and financial barriers, including out-of-pocket costs, increasing information and awareness through clear communication, improve adherence to the lung cancer screening recommendations, those 3 things that I just went over, continue to engage the primary care community and support the referring primary care providers into our lung cancer system, discuss cultural beliefs about seeking healthcare and specifically how it relates to lung cancer. We need to dismantle the psychological and social barriers that prevent attendance at screening, get rid of the stigma that goes along with being a smoker. We need to provide advocates or navigators to guide patients through cancer treatment once they are diagnosed. And then we need to give information on ways to reduce cancer risk, including healthy skills and behavior for children and adults, including diet and exercise. So summary. Here are the 3 parts again. So part 1, I hope I outlined how lung cancer is a major problem in Kentucky and the #1 cancer killer in Kentucky. Part 2, I hope I showed that we have made tremendous advancement in lung cancer treatment, and these will continue to improve as we get better treatments and more understanding. So this makes access to care for everyone of paramount importance both now and in the future. So again, this is not the disease or the treatment of the 1990s or even the 2000s. Part 3, we discuss lung cancer screening and access to cancer care and the barriers which we need to overcome with the teamwork approach with the healthcare system and the community working together. So how do you refer a patient to Norton Cancer Institute? Here's the phone number, and also nortonepiclink.com. So one thing I would like to add is that we've really built a program around lung cancer screening and lung nodules and lung masses. So I'm trying to make it easy where if you do a lung cancer screen and it looks like the patient needs something and you don't know what that is, they need a biopsy, they need to see a surgeon, they don't want to do surgery, maybe they're metastatic, they're more advanced. We want it to be easy for you. So you refer them into our program. We have a tumor board, a high-risk thoracic clinic every Wednesday where they come here to Brownsboro, for instance, and we discuss their imaging and their case. Before we see the patient, we have a thoracic surgeon, we have a pulmonary doctor, we have a radiation doctor, we have myself. And so we have a plan for the patient before they even get into the exam room. Once they're in the exam room, they're seen by everybody they need to see. So they're seen by me, by a surgeon, by a lung doctor if they need a bronchoscopy, whatever they may need. We have a full service here. And so the patient leaves one visit having seen everybody they need to see, and they have a plan of action and they know exactly what's going to happen. So that's something that we've really built here, and it's worked extremely well. And with that, that concludes my presentation.
Hey, thanks, Dr. Lai. A couple of questions came in, but I wanted to add a little bit on to where you finished and kind of ask you a couple of questions. One thing that we had started lung cancer screening, and I know a few of the attendees here have referred into that program. We acknowledged that it engaged a different level of conversation with the patient when they didn't have symptoms, right? And we could show them a CAT scan, and we could talk about the negative effects of cancer or of smoking on their lungs. Okay. So not only did we maybe not find cancer, but we diagnosed other disease processes within their body, but we had a pretty robust response to smoking cessation in those conversations. I don't know if you've seen the same thing with screenings in general and just opening up like a health prevention or promotion approach to patients.
Yeah, so I think once a patient kind of sees what's going on in their lungs and they're able to visualize it, a lot of times that's pretty eye-opening. And, I'm pretty honest with patients too. I said, you could get away with smoking when you were in your 20s, but these are patients that are now in their 50s and 60s. Many of them have had decades of damage to the lungs. And so it's pretty easy to see on imaging what they're doing. Now, will that motivate all of them to stop? I wish I could say it does, but it doesn't. But I think that's part of building a relationship and part of, having those conversations on the benefit of smoking cessation. I also try not to, lecture them. I mean, I think most smokers know or think that they should quit. How many actually want to quit? That's a different discussion. So when they're ready to like, hey, I want to quit, not that I think I need to quit, that's a little bit different situation. So that's when, we get more aggressive at trying to help them quit smoking.
Yeah. Okay, thank you. So a couple of questions that came in. First question was, does the type of cigarettes, menthol, cigars, etc., influence the rate of cancers? Okay,
good question. So here's the thing with cigarettes that people need to understand. And I'm kind of driven crazy by talking to people about it because it's always the same discussion. Well, I'm doing good. I smoked 1 pack, or I smoked 2 packs. Now I'm down to 1 pack, or I smoked 1 pack. Now I'm down to 5 cigarettes a day. The length of time that you smoke, so the number of years that you smoke, is probably 100 times more impactful or dangerous than the amount that you smoke per day. So really, that's the point to drive home, It's just that repeated DNA damage, that the repeated carcinogens. You know, the other things are, there's really only two risk factors that you can't control as far as developing cancer. The first is what you inherited from mom and dad, you know, your genetics. You can't control that. The second is, as the human body ages, all of us, our ability to fight off cancer goes down. All right. And so that is just compounded by years and years and years of repeated injury. So, you know, the kind of cigarette you smoke, how many you smoke, that's not as important as how long you smoke. So I think that's the important thing to drive home.
Okay, so this is kind of a second part of the question. This same person asked, are there any studies in screening on young adults?
There are not. And so I think we made strides from going from 55 to 50 years old. Do I have, you know, 40-year-olds? Of course. I actually have 20-year-olds that have developed lung cancer in Kentucky. So, you know, at some point you have to cut off the screening somewhere. You know, that's the cutoff they set. I wish for some of the worst states in the country, they would have, you know, even more broad or more generous cutoffs, but they don't. So no, if someone's asymptomatic, there is no screening. But if they have any symptoms at all, that's where I would get a CT chest. You know, if they have weight loss, coughing up blood, you know, something out of the ordinary, I would just go ahead and get a CT of the chest.
Yeah. So on that, in that same lane, does the age of person, which you kind of answered this, but does the age of person begin smoking increase the risk in lung cancer?
Yes, it does. My youngest patient I have was 4. His granddad gave him cigarettes because he thought it was funny, and he's been smoking since he was 4 years old. So yes, it definitely makes a difference what age you start. Again, it's just the length of time you smoke is much more important than how much you smoke per day.
Got it. What percentage of lung cancer diagnosis, so we're going to switch to non-smokers, okay? And I know this from my practice. There's definitely a percentage of patients who never touched a cigarette, didn't have secondhand smoke, maybe have had some exposures to radon and some of these other chemical exposures or environment. But what percentage of lung cancers are non-smoking related?
So for non-small cell lung cancer, about 19 out of 20 are smoking related. All right. For small cell, virtually all are smoking related. So there is your uncommon, and you know, I have a couple I presented in my patient examples there. But there are patients that are non-smokers that have lung cancer, unfortunately. And like you said, a lot of those are some type of environmental exposure, maybe some hereditary genetic risk, something like that. I had one patient, she was diagnosed in her 20s with an adenocarcinoma, and she ended up having a hereditary mutation. So those patients are out there for sure.
Thanks. This is from another attendee. I had a family member diagnosed with stage 3 lung cancer in 2019. He is now in remission after extensive treatment with radiation, chemo, and immunotherapy since the location was inoperable due to it being within the bronchial tubes. He was diagnosed thinking he had acid reflux. Should doctors be more aggressive with smokers with diagnosing simple symptoms to verify that it is not cancer, and also should immunotherapy be more widely emphasized?
Oh, great question. Boy, this one's a rabbit hole.
Two-part question.
Yeah. So as far as doctors being more aggressive with smokers, I mean, you know, I'm probably biased because that's what I take care of. I say yes. But the primary care doctor, the most common symptom of lung cancer is cough. So, you know, smokers have increased cough all the time. They have COPD exacerbations, they have bronchitis, they have pneumonia. So, you know, I don't know. It's hard for me to put much blame on them, because we'd be doing CAT scans like crazy if every time a smoker had a cough, we did a CAT scan. Now, if it's a cough that doesn't go away, or it's associated with weight loss or some other alarm, yeah, I would be very aggressive with that. I think the big thing we need to do is just start screening people at age 50. Like, let's just start screening them. And so, you saw the data there, where 15% or less or so. So we got a ton of patients that we could really help. I mean, and this is the problem for our state. So that's the best thing we can do, is just identify or try to get patients that aren't coming to the doctor, get them to come in to get this screen. I mean, this really is a life-saving procedure we can do.
Yeah, I think that to add to that, for those that are primary care APPs or doctors on this call, the way I approached it was because we saw a lot of lung pathology that wasn't always cancer, right? Even being in thoracic surgery. And if you had a first degree relative that had cancer, and then you had some symptom and you were a current smoker or had some length of smoking, I definitely increased my suspicion or concern just knowing they had a relative, a sibling or a parent that had lung cancer. I pulled the trigger a lot faster on those patients with doing CAT scans and things like that when they came in with complaints. So I completely agree. So the second part of the question, do you
Yeah, what
remember,
was
was it
the second part?
immunotherapy
Oh, yeah.
that being
Okay.
more
So,
widely used?
yeah. So immunotherapy. So we're using it more and more. We just had a nice discussion over the past week over email in the group about the use of immunotherapy in the neoadjuvant setting. So these are patients that come in with big tumors, but they're operable. We can resect them. So they're big tumors in the chest, nowhere else. Does adding immunotherapy before they have surgery help? And so there's some data that says that the answer is yes. And there's going to be more trials and data coming out that I think is going to support that even more. In my practice, I'm a huge proponent of getting as much information as I can about the patient's cancer. So I do a lot of molecular testing. All these places like Cancer Treatment Center of America and MD Anderson, and they all talk about precision cancer care or personalized medicine. We do the same thing, or I do the same thing. We just don't market that. So really, patients within the tumor. If I don't find that, and oftentimes even while those tests are pending, I get my advanced patients rolling on treatment with immunotherapy. So all of my stage 4 cancer patients get immunotherapy. My stage 3 patients, they get radiation and chemo followed by immunotherapy. That's standard of care. And then, stage 1, most of those you can do surgery and they don't need anything else. The stage 2s, now we know that for many of those, they can have a resection, so it can get removed. And then they can get some chemotherapy followed by immunotherapy. That's based on the ADORA trial that came out in the last year or so. So we're doing more and more immunotherapy in all settings. So yeah, it's helpful.
Okay, next question. Thank you for this needed presentation. My husband, who has prostate cancer, on a chest x-ray screening in the ER for another problem, had something noticed on the x-ray, an abnormality. Turned out with a biopsy, it was prostate cancer cells in the lungs, and the bone scans are still negative. So I think that they were just commenting on doing additional screening.
Yeah,
we see a lot of metastatic disease that shows up in the lung for sure.
Yeah, so that the lung cancer screening, the all-cause mortality, so there patients live longer that had the lung cancer screening, and it wasn't only from catching lung cancer. So you catch other cancers, you can catch aortic aneurysms. I mean, there's lots of things that you can catch, lymphomas. So there are other things that you catch on these screens that you may otherwise miss. So it sounds like this is this could have been another situation where we found something that we weren't necessarily looking for.
Yeah, I remember we had a patient one time that we did a lung cancer screening on. They were screened, had a large aortic aneurysm. When we called with the results, they said, yes, I've been having chest pain. They went directly to the emergency room and had
Yeah.
surgery like within 24 hours. I was like, and that probably saved that guy's life. So yeah, it's pretty impressive. And all kinds of things, diaphragmatic hernias.
Well, because smokers are at risk of other things, right?
Right,
Yeah.
right. In your opinion, what do you think would be the most effective strategy to reach at-risk patients that have not yet been screened?
Well, it
Great
depends.
question. And that's
Yeah.
really a lot of why we're here today.
Yeah.
This is one strategy, but yeah.
Yeah. So I think it depends on if they've even heard of lung cancer screening. If they've never even heard of it, I think you tell them what it is. I describe it as, kind of like women get a mammogram, right? You get a mammogram every year and you're really looking for changes. So one thing I try to educate them on is that we don't just get one scan and, say, well, I'm good, I don't ever need another one. That's not the idea. The idea is you're getting a scan once a year and we're looking for development of nodules or something we can act on early. So I think just trying to educate them on the benefit of what it is, that it's very low risk, very high reward. It should be covered by insurance. Hopefully the financial barrier, we can overcome that. There's just a lot of positive things that can come out of it compared to not getting it. But I mean, I would guess that most smokers don't even really know that it exists or really the benefit of it. So I think a quick 60-second discussion, a lot of them may feel better after getting the screening and knowing that everything's okay. Now hopefully they'll still quit smoking, but I think just letting them know that we're here to help and try to intervene early would be helpful for them.
And I also think that and part of what Dr. Lyon, he also participated in a community discussion with local leaders on how do we get to those hard to reach or those areas where we know that there are healthcare disparities. And I think that us as clinicians being very intentional, if you're delivering care in a zip code, back to kind of how I opened the program, where we know that high incidence of cancer, low screening, we really need to, as an organization, support that team in reaching those patients that are hard to get to. And it's something that will take years to get to where we need to. Even though we have great rates in screening here, it's hard to believe we're in the teens.
Yeah.
And we're missing 80+% of the people that qualify for screenings, and we're not even there yet. I mean, if only we could reach those.
Well, and so after my community presentation, somebody that I'm close with came up to me and said, that was a great presentation. I loved everything you said, but let me just tell you, the people that need to hear that, what you just did, will never hear it.
Right.
And, that I think is the challenge. Like that is the barrier really when it comes down to it. How do we get this information to those people? And so that's where, we need the help of the people that are on the front lines, the PCPs and everybody else. Is it marketing? Is it stuff in the office? Is it working through certain community outlets? Like, how do we get this information to the people that would benefit hearing it, right? We all can know it, but we got to get it to those, 15,000 eligible people that don't necessarily even know about it.
So this was a great question. Secondhand smoke or secondhand exposure, right, to smoke. Mother died of lung cancer. What should one do as far as screening? They don't qualify. So they had a lot of secondhand smoke. And then they also, their parent died of cancer.
Yeah. So again, there's no screening that's approved. So if there's some other symptom or concern, or you do a scan and you see a nodule that you want to follow, that would be it. But, as far as family history, because, lung cancer is not really thought of as a hereditary cancer like some breast cancers would be, for instance. And there's no screening for non-smokers. So even with a mother or a brother, whoever, first degree relative with lung cancer, they would not be eligible for any screening program, unfortunately.
So in past years, this is another, they used to do x-rays on every patient that got admitted to the hospital. Should we, and we didn't really talk about the difference between x-rays versus CAT scans and the sensitivity of it, which is probably a good point. Should we return to doing x-rays?
No. So they try to do multiple screening programs, which basically that's what we're talking about here, just with ER patients. And x-rays have never been shown to be beneficial. In fact, that's the reason why this study was so significant, is for the first time we found something, and we found a population of smoking patients, that 3 criteria, where we could really make a difference. Now we have to do sometimes hundreds of screens to find one lung cancer, but that's worth it, right? Especially in our state.
Okay, these 2 questions we could probably combine together. Have you considered partnering with the Institute of Health Equity? Okay, first. Second, are there plans to incorporate screenings and outreach with the West Louisville Hospital?
So yes, I will partner with whoever to help this. I'm sure Norton shares that as well. As far as the new hospital, we'll be, from what I understand, we are going to have imaging there. I would be a proponent of having lung cancer screening there. I don't know why we wouldn't. Again, you all should think of this the same way that you do like mammogram, colonoscopy. It has the same level of recommendation. So, if we're offering mammograms, we should be offering lung cancer screens. And so, I don't know exactly what they're putting in the facility there, but I would be a fan, or I would push for lung cancer screening there. Now, what we do after we find a mass or a nodule, that gets a little trickier, because now you need a whole bunch of specialists, and the patient may need to go to a facility where we have specialty care all grouped at once. But they're not having to travel to Nashville or Cincinnati or somewhere like that. We do all that right here, and we do it very well.
And as far as the Institute of Health Equity, both Dr. Lai and Dr. Cerrone, one of our surgeons, met with Dr. McCants and the team to really highlight the need for us to have this discussion on lung cancer. And so we are partnering with that team as we, and even in planning for this today. So yes, we are integrated with that team at Norton.